So Ilana works as an anaesthetist in a major trauma center in Sydney, Australia, with special interests in orthopedics and trauma. She also works as a pre-hospital and retrieval consultant for NSW, New South Wales. Yep, New South Wales Aeromedical, both as a clinician undertaking retrievals and as a State Retrieval Consultant, helping coordinate taskings of the NSW Aeromedical Services. In her involvement with critical trauma, both patients in and out of hospitals, she has developed her interest in blood product resuscitation and currently coordinates governance of the State Retrieval Transfusion Procedure, supporting blood to retrieval teams and remote hospitals.
So thank you for the invitation to be here. As you can probably tell, I'm not originally from Australia. I'm actually from England. I'm working on the Aussie accent. I'd just like to, over the next 20 minutes, try and cram in a little bit about what happens down under. From my experience working in New South Wales and for New South Wales Ambulance, but also what I've learnt about and seen from some colleagues around the country. I thought I'd start with a couple of pictures to make you feel a little bit at home, especially the one that is a ski resort in Australia. If you didn't know, you can go skiing in Australia. Although when I arrived here the end of last week and popped up to Whistler for a couple of days, I was skiing on Monday, and I don't think I've ever seen that much fresh snow and powder. I'm not sure I was actually skiing in it, more flailing, but it was a lot of fun. Okay, so what I'd like to do, or what I've been asked to cover, and I will attempt to cover, is how the Prehospital Retrieval Medicine, or PHRM, or PHRM services have developed in Australia, and a little bit really about where they came from, the professionals currently involved, and how it addresses health inequalities in Australia. I just wanted to start with a story that not only inspired the birth of prehospital retrieval medicine in Australia, as far as I can tell, but also really reminds us of the why, and we've spoken a bit about that this morning. What do I mean by this? Well, there's a great TED talk that you can see up there by someone called Simon Sinek, talking about the success of organizations, commercial or not, and that this success doesn't come from what they can do, but truly from understanding why they do what they do. And the why really always, as we've heard this morning again, starts with the patients. So this is a story starting a few years ago. On the 29th of July 1917, 29-year-old Jimmy Darcy was caught in a cattle stampede up in northern Western Australia. He was found by some of his colleagues having been thrown from his horse, and the horse fell on him. He was taken through. He was put into a horse and cart, taken through overland tracks 12 hours to the local town called Halls Creek. In Halls Creek at the time, the highest level of medical expertise was Fred Tuckett. Fred was the local postmaster. He had a first aid certificate. At the time, Jimmy came in, and Fred, rightly so, thought he needed some help. So he got on to, via Morse code, sent some telegrams around to the local towns to see if anyone could come and help. No one was available. So Fred tried Dr. Joe Holland down in Perth. Perth's about 2,000 miles, so almost from here to Winnipeg away. Joe, or Dr. Holland, had helped Fred with his first aid course, so he knew him. So again, through telegraph was messaging. Dr. Holland felt, and through, as I said, Morse code, they diagnosed that Jimmy might have some degree of bladder injury. I'm not quite sure how they achieved that. Dr. Holland really felt that from the information he was being given by Fred, that without surgery, Jimmy was probably going to die. Fred was understandably reluctant, but as Jimmy got worse, he felt he had no choice. So with morphine, because there was no anesthesia, with some probably rudimentary equipment, and with instructions via Morse code, Fred operated on Jimmy twice. Jimmy survived these original surgeries. In fact, first reports were that Jimmy was rallying. So, with further messages telegrams down to Dr. Holland, who was essentially said, "I'm on my way." Unfortunately, at the time, that wasn't a quick affair. So he got a boat, a Model T Ford, which apparently was one of the original cars, which then broke down. Then also horse and cart, and arrived in Halls Creek on August the 23rd, so almost a month later. Having survived almost a month after his original surgery, Jimmy died the day before Dr. Holland arrived. That story made headline news around Australia at the time and led the public, along with Dr. Holland, to lobby for what they called a mantle of safety, such that healthcare could be brought to the people living out in the bush or in remote Australia. That same year, Reverend John Flynn, pictured here, who you may have heard of, founder of RFDS essentially, received a letter from a Lieutenant Clifford Peel, who had been a medical student in Victoria, one of the states in southern Australia, but had been drafted into the Air Force. And Lieutenant Flynn spoke about the use of using aviation, so planes, which were relatively new at the time, to provide or bring medical care to patients in the outback or rural Australia. Sadly, Lieutenant Peel died during World War I, but John Flynn continued to campaign for many years for this provision of aeromedical services around Australia. In 1928, they received a large bequest left for an aeromedical experiment, as it was called, and the Australian Inland Mission Aerial Medical Services was born. On May the 17th, 1928, they flew their first mission. This is the service that has since become what you may have heard of, so RFDS, so the Royal Flying Doctor Service of Australia. And this story, while set years ago, when medicine was not as advanced as it is today, still reminds us of the why we do what we do. We strive to provide the best medical care for patients like Jimmy, regardless of their location. We strive for equity of care. So where are we today? A little geography to start. So this is Australia, a land of kangaroos and koalas and some of the deadliest reptiles and spiders you will ever find. It's great. The population of about 27 million, broken up into the states and territories that you can see there. Our climate is typically hot, and we're the 6th largest country by size, coming in short to Canada's, I think, you're second. If you want to do a few comparisons, there's some numbers, populations and sizes of the countries. So kind of probably some similarities in there that we'll cover probably in the next slide, because just knowing the size of the population and the landmass doesn't really tell the whole story. Apologies if this is a little blurry. This is, again, the states and territories of Australia, but this is a population density map. And I think it helps highlight the two significant challenges that we face in Australia and maybe similar here in Canada, delivering healthcare to all Australians, the remoteness of our population, and the centralisation of our health services. So for the start, the remote population, so the red on the map is the very remote. So this accounts for just under 1% of the population in Australia, which is still around 250,000 people. If you want to know distances, or I suppose size, east to west, is essentially equivalent to about Vancouver to Toronto. So a small but significant number of our population in Australia live across a large and remote landmass. Travel times to and from many of these areas are long and transport options are limited, as are the medical facilities in many of these areas, which brings us to the second point, the location of our health and specialist resources. I don't know if you can see, but there's some small blue dots located around. Those are our major cities and where 70% of our population lives, where our big centres are, our trauma centres, our paediatric centres, our ECMO centres. But 30% of the population, which is about 8 million people, live outside of these areas to varying degrees of distance. The green, the yellow, and then the orange is a mixture of rural and regional areas, with a mixture of healthcare facilities and critical care capabilities. For example, in South Australia, that one in the middle at the bottom, if you need a ventilated bed, you need to come into the blue. There's one. I don't know how to scroll down on my notes. Can I do that? You do that. Perfect. Too many notes. And you could ask and go down the line of why not create more specialist hospitals and services. There's often obvious resource challenges to this, but there is also some evidence for more specialist service, so trauma, neurosurgery. Actually, centralisation has better outcomes, better morbidity, improved morbidity and mortality. So putting it all together, Australians need to travel to access higher levels of medical care, and these distances can be significant. Prehospital retrieval medicine services in Australia provide a medical transport platform for patients with a range of illness severities. For our most critically ill and injured patients, they also bring the critical care to the patient, reducing time to access interventions, treatment, and reducing morbidity and mortality in our most critically ill and injured Australians. So what does it actually look like? This is another map, all the states and territories. Essentially, we all have some degree of pre-hospital retrieval medical services that have been probably running for a number of years. They are state or federally funded, predominantly state funded. They all have central coordination to varying degrees depending on the size of the service. And these are typically, as you saw earlier, a multidisciplinary team in a central control room, independent of the hospitals. We carry out inter-hospital and pre-hospital. Essentially, it's similar to Stevens, but we group all the, from either small hospitals or between larger tertiary centres or bigger hospitals, we group them all as inter-hospitals. And probably unsurprisingly, that is a significant amount of the work that we do in these services. That writing is far too small for me to read. Thanks. Should have brought my glasses. I don't need glasses, it's fine. We do have some subsections, so in the larger states, and I think this might be workload related, we have paediatric and neonatal services. They typically run the inter-hospital, so moving between facilities, they provide advice. But that our main services in each state can also go out, as in Scotland, to any of the pre-hospital paediatric or neonates that need help. And we cross-cover a lot, so sometimes if there's not a paediatric service, then they can ask for help from the general services, and we share a lot of resources. ECMO, and by ECMO, I mean the ability to take a team that has ECMO capabilities and often retrieval capabilities and go out and either put a patient on ECMO in a smaller centre or pick up a patient that's already been put on and bring into a central hub. And that is available in Queensland, New South Wales and Victoria. And Victoria also covers some of the other states and territories to support them. And there are some ECMO CPR capabilities, a relatively robust one in Victoria and a trial one in New South Wales at the minute. All of these services have robust governance and education, as we've heard about earlier in some talks. And the teams, who are they? Typically, it is a doctor paramedic or a doctor flight nurse team. There is a significant number of flight nurse only for some less critical transfers. And in New South Wales, that accounts for just under half of some of the inter-hospital transfers that we do. But for any critical patients, all of these services will typically have a two-person team. In 2 of the states, they do run some dual paramedic responses, and in 1 of those states, they're introducing doctors to their service this year. A little bit more about those people. Our nurses, they are critically care trained, typically emergency and ICU, and depending on the state they work in, they may also be required to have midwifery training. They are not only involved in going out into the actual missions and looking after patients, they're involved on the phone with triage and a lot of telehealth. Our paramedics receive critical care training from the organisations they work in. That's above the EMS services that they've worked for, and depending on the state they work in, might be required to have search and rescue training as well. Typically involved in the cases, but also in triage and tasking of the assets. Our doctors, apologies for that terminology, so we have a lot of training doctors that come through, but these are doctors that pretty much are at the end of their specialty training. So senior registrars, I think the equivalent is senior residents here. Those are our temporary members of staff in some services. So they'll come to us typically for a year, undergo rigorous training programs, have consultant oversight at the whole time, but come for a year and then go back into their training programs or wherever they were going back to. Our specialists or consultants are our permanent members of staff. Typically, the specialties you'll find is emergency, anesthesiology, and intensive care. All our specialists also work in hospital, so they work between both pre-hospital and in-hospital for maintenance of skills. And our specialists also, as well as being involved in the flights, are significantly involved in triage and telehealth around the States. And then there's our pilots and our crewies. Predominantly from the military. I think that's to do with the number of hours required to be able to get onto these kind of programs. But then also with EMS training in the services they work in, and possibly some search and rescue as well. I just wanted to take a moment to focus on this multidisciplinary team. how by bringing together these different skills and experiences, we really do see a whole that is greater than the sum of its parts. Managing complex patients in unfamiliar and challenging environments, we see the need for this advanced clinical and logistical experience to come together. In practice, this makes for a critical care team where each member is made better by the other. A synergistic relationship providing critical care to some of our most vulnerable patients. I'm just going to cover in a little bit more detail a couple of the states. One, because I work in this one. This is New South Wales. We are about equivalent in size to BC. We're a little bit smaller, actually. We have a slightly larger population. We have 11 bases that you can hopefully see there. Broken Hill, as was mentioned earlier, is that one kind of out on its own on the left, which is actually closer to South Australia than it is to Sydney. So we have 3 fixed wing bases. The one in Sydney is actually has 10 shifts a day with 3 minutes. Well, okay, I'll be quick. 3 shifts a day, 10 shifts a day. So a number of fixed wings going out of there, flight nurse fixed wings. The rest are helicopter bases that also have some road response. So we have about 8.5 million people in Sydney, 11 bases, which is equivalent to about 13 or 14 critical care teams on, and that's 24/7. Our Aeromedical Control Centre, which is our control centre in Sydney and covers everywhere, takes about 29,000 calls or bookings a year, and we fly about 50 missions a day across them. It's in New South Wales. We support search and rescue as well. We don't have a specified separate agency. It's the EMS services altogether. This is some flood response that we did a couple of years back, working together with other EMS agencies. And our paramedics are also rescue skilled. And there's some beautiful mountains nearby that people often get stuck on and injured on. And that's one rescue that we did there. Briefly, this is Queensland, a bit further north, similar size population to BC, but twice the geographical size. They have 21 bases, as you can see there. The majority of their population is, as in New South Wales, along the coast, with most the central resources, the control centre, all down in Brisbane, but with some ICU capabilities up the coast, and a lot of where their assets are located. But obviously, as you go inland, that gets pretty sparse. As in New South Wales, the majority of their work is into hospital, and they fly slightly more at 68 missions per day. So how does PHRM address health inequalities? Well, we've spoken about the providing the ability to physically move a patient in a timely fashion from a small health centre, hospital, or the side of the road, to a medical facility that can provide the care that they need. They also bring critical care skills and experience to the patient, not accepting they need to get to a hospital before they can get the care they need. Critical care is also brought about through telehealth, part of the prehospital retrieval medicine role in a number of the states and territories. Telehealth provided by clinicians that understand, we've spoken about this already, the skills available and the limitations of the facilities that the patient's in, and can work with local teams to provide the care. But clinicians that also understand the state or territory healthcare facilities and can provide the mix of clinical and logistical support. Pre-hospital retrieval teams in Australia also work to provide culturally appropriate care to all Australians, including our First Nations people. So we have Aboriginal and Torres Strait Islander peoples in Australia, accounting for about 4% of the population, which is about 1 million people. Highest percentage in the Northern Territory, which is about 30% of the population. And though there continues to be migration into the bigger cities, a lot of these communities remain rural and remote. So providing care to remote Australia carries the challenges we've already spoken about, but provision of healthcare to remote and rural First Nations peoples also carries historical and cultural barriers. Barriers such as a significant mistrust of authority, and by association many hospitals and healthcare facilities, differing health beliefs and practices, and communication barriers both in language and health literacy related. Pre-hospital retrieval medicine services may be the only link to health services for many remote communities, so working with elders, liaison officers, and the communities to overcome these barriers is key. One such example is CareFlight in the Northern Territory, which is one service, and has been working for a number of years to build trust and relationships, understand different health practices, and using local languages and dialects to improve communication and community health education. And these are a couple of the projects that you can find on their website they're running at the minute. almost there. So a bit more recently, we are following as similar, if you heard about in the UK, we're not quite as set up at the minute, and the UK is a long way to go for an exam, but maybe you can make a holiday out of it as well, I don't know. So in Australia, we've more recently, a lot of pre-hospital retrieval medicine clinicians in Australia and in New Zealand have teamed up with the Australasian College of Emergency Medicine to try and more formalise our doctor training and work on our collaboration and our networks. So we set up a standard for clinicians coming into the specialty called the Associateship of Prehospital and Retrieval Medicine, which has been running for 4 years now. It's 6 months of training with working in a service with ongoing assessments and then an end exam set by specialists working in the field. The college has also set up this farm network. So pulling together clinicians from around Australia and New Zealand to talk to each other, to understand our services better, to learn from each other, and to share in that learning. We now have over 500 members, as well as buy-in from our colleges, so from anaesthesia, from ICM, from EM. To finish, promise I'm there, I just wanted to take it back to where it all began and the importance of keeping in the forefront of our minds the reason of why we do what we do. As I said, medicine has advanced quite a lot since 1917, but the remoteness of some of our populations in Australia has not. To provide equity of care, we have to use these advanced resources we have now to give for access. In Australia in 2026, we have a large network of advanced pre-hospital and retrieval medicine teams and services with the skill mix and resources to take critical care to patients like Jimmy, to stabilise him and get him to the specialist centre where all of his clinical needs can be addressed, providing equity of care regardless of the location, and giving Jimmy the best chance of overcoming his injuries.